Thank you very much for that introduction. So good afternoon, everyone, and good morning from the UK. It's a pleasure to be talking about the Recovery Trial, which is a platform randomized trial of treatments for COVID-19. I'll tell you a bit about the development, the progress, and the lessons and the legacy from the Recovery Trial. So if I take you back a bit in time to a call for global action as outbreak spreads, I'm going to take you back a bit further than you might expect to 2009, the swine flu epidemic. And you can see this is some examples of some UK newspaper headlines about the killer flu. I'm just going to look back at how we did on clinical research studies in 2009. So one of my PhD students looked at what was achieved in terms of clinical trials for swine influenza, remembering that in hospitalized patients, we don't currently have any licensed antivirals for influenza. Neuraminidase inhibitors are widely used, but they're actually not licensed based on randomized controlled trial evidence in hospitalized patients. And so if you look at the registered trials, there were about 4,000 patients was the aspiration to enroll in randomized controlled trials. The actual number enrolled was just over 500. And the number of patients enrolled and the results published was tiny. And so, and none of that was published during the 1 year of the 2009 pandemic. So really a very poor performance. And you're all familiar with epidemic curves. So I like to think of it as an epidemic curve of ambition. There were a lot of ideas and ambitions, but it really did not translate into protocols, into patients enrolled into studies, and left us with no evidence. And more than 10 years later, we still don't have any licensed antivirals for hospitalized patients with influenza. So it really was, I think, a failure of clinical research. So bringing us forward, we want to shift this curve so that perhaps we're a bit less ambitious, but actually we deliver on our research and we change the evidence base and we improve care. So a more recent outbreak when the whole world must take action again, is COVID-19. You can see that the quality of some of the UK newspapers has not improved, but has the clinical research improved? So when we started to think about trials for therapeutics for COVID-19, we knew we had an unprecedented clinical challenge. We knew that very severe disease being seen in Wuhan, with healthcare workers being affected. In the center is Professor Bin Cao, a great physician in Beijing who was sent to Wuhan to lead the clinical research response. And in bed is the hospital director. Really a very serious situation with overcrowded hospitals, healthcare workers under extreme stress. And this was now spreading to other countries. This is Italy here. So we knew we'd have a very large population of unwell and often elderly patients. Alongside the challenge in the healthcare setting, we also had huge therapeutic uncertainty. There were many candidates being proposed, many opinions, but no reliable data really. We had politicians saying that they were promoting certain drugs and they really were not qualified to do so. And we had poor quality, uncontrolled, comparative observational studies claiming miraculous benefits of drugs, which people were believing. So we were in a rather chaotic situation. So our early experience was working with colleagues in China. So myself and other colleagues supported Professor Bin Cao to lead studies in Wuhan. We had our very first call about clinical trials in Wuhan on 2nd of January. And we agreed to very rapidly set up some trials. And the first one was going to be lopinavir-ritonavir, which had showed some benefit in animal models of coronavirus and potentially in SARS-1, and was being tested in MERS, and we had a protocol. And then we also tried to secure remdesivir, you can see here in green. So we acted very quickly. From the 1st of January to the first patient enrolled in the lopinavir-ritonavir trial was just 20 days. So we were extremely pleased with that. And actually, at the time, I gave a presentation saying I don't think we could do better than that. I think 20 days, less than 3 weeks from the first conversation about a trial to enrolling the first patient is pretty amazing. So we were very pleased with that. And then not that long after, we enrolled the first patient in the first placebo-controlled trial of remdesivir, just in early February. So we moved very quickly in Wuhan. So what happened? Well, this is what happened. The control measures in Wuhan, the public health control measures, led to a very rapid containment within Wuhan. So the patient recruitment dropped off very quickly. And so we ended up with 2 trials that were successfully started, ran very well, but didn't recruit sufficient patients. So both of them only had a couple of hundred patients in them. And they've been published, but really gave inconclusive results. And what you can see is that this is just the sample size requirement. So if you're looking at a mortality benefit, and you want to say have a 20% proportional risk reduction on a 20% case fatality rate in hospitalized patients, which was roughly what we were seeing, was sort of 20-25% hospitalized case fatality, you're going to need more than 2,000 patients per arm to see a 20% reduction in mortality. And it's only when you get up to sort of what are perhaps unrealistic expectations of 35-40% reductions in mortality that you get into the hundreds of patients per treatment arm. This is with a 90% power at two-sided P of 0.01. So this would be a very convincing result. But for a convincing result, you need a big trial. And a recent review by FDA colleagues looking at all the trials registered for COVID, this was over 2,000 trials with nearly 3,000 treatment arms, showed that the vast majority were completely underpowered and would not yield actionable information. So people were still making the mistake, are still making the mistake of underpowered trials, with 95% of them underpowered. So a huge waste of resources and in many ways unethical to do these underpowered trials. So the design of the recovery trial in the UK, which followed on very rapidly after the Wuhan trials, was we knew we had to be quick. If we wanted to catch the upswing in the UK and not have a situation like we did in Wuhan, where control measures led to declining recruitment, we had to be very quick. It had to be big, unlikely to be a miraculous cure for an acute severe respiratory viral infection, and moderate benefits would be plausible and they would be very worthwhile in a pandemic setting. If you can reduce mortality by 20%, you'd have a huge impact globally. So in these circumstances, you really want to design a trial that's looking for modest benefits. And it must be simple because we have a very stressed healthcare system, stressed healthcare workers and stressed patients and relatives. We needed to make it a simple trial. So we decided we would really cut down the data collected and rely on an unbiased objective outcome of death, which would mean that we could do this as an open label study, which massively simplifies doing a large platform trial. And we decided to use a factorial design, which is where you can be randomized to more than one comparison. So because some of the interventions were targeting different pathophysiologies, they could be given in parallel. So for example, here, you could be randomized in the green blocks to colchicine or dimethyl fumarate, which are mild anti-inflammatories. Concurrently, you could also be randomized to antibody therapy, so convalescent plasma, Regeneron, which is a monoclonal or usual care, and concurrently you could be randomized to an antithrombotic therapy, aspirin or not. So this was very efficient because one patient can contribute to 3 comparisons, and that's worked very well, which again increased our efficiency. Made it very simple. Trials don't have to be complicated; they can be simple. So we had very simple eligibility criteria. Many trials have very complex inclusion-exclusion criteria. We wanted to make it simple and make sure that the results were applicable broadly. So just anybody hospitalized with suspected SARS-CoV-2, an unbiased objective outcome of mortality. And we randomized patients between drugs that were both suitable for that patient and available at the site. So we didn't have to make sure that every site had every drug available. If the drug wasn't available, then that randomization just was not run. And a very simple follow-up one-page case report form initially, with extensive data linkage to make sure we had completeness of outcome without overburdening staff. So actually, we have extensive data linkage. You can see here, these are all the data sets that we have data linkage. More than I think 15 data sets are linked. So we have very high completion of the primary and secondary outcomes, more than 99%, because we have extensive data linkage. And so it doesn't require us to personally follow up all the patients or to burden healthcare staff. So we get regular downloads of data with linkage by unique identifier. And that includes both, death data, but also admission to intensive care through critical care audit pathways, and use of disease-specific data sets like a renal registry to see which patients required renal replacement therapy. And so implementation, this is the first wave of the epidemic curve in the UK in sort of March 2020. The sawtooth pattern is just artifact of weekend reporting. And so I had a meeting with the Chief Medical Officer and we got the green light, so his verbal approval to proceed with a large platform trial in the UK on the 9th of March. We enrolled the first patient just 9 days later, so we managed to beat our 20 days and we got it down to 9 days. So 9 days from writing the first draft of the protocol and getting the green light to enrolling the first patient. And then within 2 weeks, we had about 1,000 patients, and within a month, we had 5,000 patients. So we acted very quickly to catch the first wave. And so by the end of the first wave, we had 10,000 patients enrolled. And this is the recruitment graph, and it matches very well the epidemic in the UK. The red line is the 7-day moving average, and you can see we very rapidly scaled up in the UK. So in the first wave, at the peak, we were recruiting more than 400 patients per day. And in the January 2021 peak, we were at one point recruiting over 500 patients per day across the UK. Because we were opening so many sites, and we had a very simple protocol, it meant we could really scale quickly. So the map shows you the sites across the UK that were recruiting, and the size of the green circles is the number of patients recruited, and some sites have recruited more than 1,000 patients, and we have over 180 active sites. And at the moment, we have almost 45,000 patients enrolled in total. And you can see at the top there, there's different countries. We've got the global numbers, but in the tabs, you can see GBR, ITN, MPL. So we're now open internationally, and there are recruitments internationally now. It's very inclusive. We made it a very inclusive trial. This shows you the age distribution of patients included. The youngest patient is under 1. The oldest patient is 103. So we possibly have got the widest age range of any trial ever. We include children in some of the comparisons. So we've got over 300 children randomized. And we also, whenever possible, include pregnant women. So we have over 100 pregnant women enrolled as well. So we've tried to make it a trial that almost any patient can enter into some of the comparisons. It is very simple, and this shows you the time to randomization. So the system collects data on when you first open a new patient record and when you get the randomization answer. And you can see here it takes on average 8 minutes from opening a randomization to getting a result as to which drugs the patient should be prescribed. So it is really very simple. So the results and health impact so far, this is a bit of an ugly slide, but it shows you over the last 600 days, so that's up to this week, the recruitment profile for the different arms. And you can see you get an upswing when we have a big wave, and then it plateaus, and then we get another upswing when there's another wave. And you can see the recruitment to the different arms over time. So you can just see how we've added arms over time, and the recruitment rate has changed as the epidemic waxes and wanes. So this is 13 drugs in the trial so far. And you can see this is the number of, in the circles is the number of patients in the comparisons. So you can see that none of the comparisons that are completed are less than 2,000 patients on active treatment and 2,000 on control. So at minimum 4,000 patients. So that gives a very robust result of efficacy or not efficacy. You know, it does take a lot of patients, but we're in a pandemic with very high case numbers, so you can run a trial that gives very definitive results with large numbers. Some of the comparisons are bigger. So if you look at, for example, convalescent plasma and the Regeneron monoclonal antibody, they're much bigger because we wanted to stratify by baseline serostatus, whether you had antibodies at baseline or not, which meant we had to almost double the sample size. And if you look over on the right, sort of aspirin and colchicine, we've got more than 10,000 patients randomized. That's because these are extremely cheap and readily available drugs. And so even if they had, say, a 10% mortality benefit, they would be useful. So we enrolled much bigger numbers to really be sure that even if there was a modest effect, we would see it. So what we have 6 negative results: hydroxychloroquine, dopinavir, ritonavir, convalescent plasma, aspirin, azithromycin, colchicine. Very clear result of no benefit, so you can stop using those. 3 positive results: dexamethasone, tocilizumab, and monoclonal antibody, Regeneron, clear mortality benefit. And we have 4 drugs that are still under evaluation: baricitinib, dimethyl fumarate, higher dose corticosteroids, because we tested 6 milligrams initially, and we're now testing up a higher dose, and empagliflozin, which is actually an anti-diabetic drug, but has sort of vascular stability and endothelial stability and anti-inflammatory properties, which have been shown to benefit in various cardiovascular inflammatory processes, and some evidence of benefit in COVID. So we're evaluating that. The impact has also been that some people didn't like the result. This is our building in Oxford, and we had a man camped outside for a week, saying that we were funded to prove hydroxychloroquine didn't work, and that we were corrupt. So I'm afraid some people don't like it when you show that their drug doesn't work. So this just shows you a forest plot of the results to date, where this is on mortality, and so if it's above 1, there's higher mortality with the active treatment, and if it's below 1 on the left-hand side, then the mortality is lower with the active treatment. And you can see, with very big numbers: dopinavir, ritonavir, hydroxychloroquine, azithromycin, clearly no benefit, even potential harm, hydroxychloroquine, but not significant. Then you come down to D, dexamethasone. Overall, in the black box, a very clear benefit on mortality, but when you stratify by baseline disease severity, you can see the biggest benefit in the more severe patients on IMV, invasive mechanical ventilation, and on oxygen, but no benefit on patients who don't need oxygen. Tocilizumab, E, a very clear mortality benefit. Convalescent plasma, a very big trial, no benefits. Aspirin, no benefit. Colchicine, no benefit. And then casirivimab and indevimab, which is the Regeneron monoclonal antibody, in a pre-specified primary outcome analysis stratified by serostatus, so whether you had your own antibodies or not. If you didn't have your own antibodies, so seronegative, then giving artificial antibodies improved survival. So there are positive results to date. The big one, I think, is dexamethasone, because it's the cheapest and most widely available, and clearly is very cost effective. So it's a very good intervention. And in the UK, another record perhaps from the results being declared to implementation was just 4 hours. As soon as we announced it, the chief medical officers of the United Kingdom wrote to the NHS and said, you need to start using dexamethasone. And so it was used that very evening, and has obviously now been rolled out and is used globally. And it's probably saved many lives. These are estimates, but an estimate, one estimate was that around 1 million lives may have been saved globally as of sort of mid-2021. Tocilizumab was interesting. I won't go into details because of time, but there was substantial uncertainty from the pharmaceutical trials, which sort of flipped between some benefit or not clear, depending on which outcome you looked at. So we did a much larger study and showed clear benefits here with these Kaplan-Meier plots of mortality, that patients who were both hypoxic and had a raised CRP, if they were given tocilizumab, the mortality was lower. And they here discharged alive. They were much more likely to be discharged alive if they were given tocilizumab again. That has entered into practice in many countries. And this just shows you, out of interest, the monoclonal antibodies result. Here, this is a survival curves stratified by your serostatus. So the top two lines, seronegative, so no antibodies of your own at baseline. If you give antibodies, in the red line here, really big reduction. So if you're seronegative, your risk of death is much higher than if you're seropositive at baseline. So having your own antibodies is a clear benefit. And if you're not mounting an antibody response, then your risk of death is about 30%. But you can reduce that substantially by giving artificial antibodies. But if you've already got your own antibodies, there's no benefit. And if we hadn't done that stratification, the overall result would have been non-significant. So it does show the importance of stratifying by biomarkers if there's a strong prior belief that they will impact on the efficacy of the treatment. So if you look at the WHO treatment guidance as of September, recovery has had quite a big impact, I think. The drugs that are recommended, casirivimab and imdevimab, interleukin 6 receptor blockers, tocilizumab, and corticosteroids at the bottom, all influenced by recovery. And two of the results that are definitely not recommended, hydroxychloroquine, lopinavir, ritonavir, again, informed by the recovery trials. So the recovery trials had impact both on using good treatments, but also stopping the use of ineffective treatments. So the wider impact, we're going international now. We're now open and recruiting in Vietnam, Indonesia, Nepal. We are hoping to open very soon in India and South Africa and Ghana, and moving also then to Sri Lanka, Pakistan. If we go back to that original slide I showed you of what happened in 2009, the anticipated enrollment in the clinical trials, actual enrolled, published and actionable, that pretty poor curve. If we replicate that curve for recovery, you can see actually when we started, we anticipated enrolling 20,000 patients in the first version of the protocol. We've enrolled over 45,000, so we've doubled what we anticipated to enroll. Because of the factorial design, we've actually published more results than patients enrolled, because each patient can contribute to more than one comparison. So the number of published comparisons, is even higher than the number of recruited patients, and we've published all of it immediately, both in preprints and then as soon as possible in the peer-reviewed literature, so that the data are actionable and have been actioned. So I think we have successfully changed the curve. In terms of other impacts, a review by Cancer UK of the time taken from funding of a trial to enrolling the first patient was 621 days. We managed to do that in 9 days. It takes around 3 to 12 years from a phase 3 trial to a drug entering clinical practice. We did it in 90 days for dexamethasone. The FDA review of 2,000 trials that are unlikely to give any answers, and we have one trial with 9 answers. And the average cost of RCTs in one estimate was around $50,000 per patient in industry-sponsored trials. And recovery, the cost is $500 per patient. So a massive improvement both in efficiency and cost effectiveness. So lessons learned, I think academic excellence can deliver big benefits, but you've got to be ready, and you've got to work with the context you've got and do things differently if you have to. Academic mediocrity in terms of poor trials have wasted resources and probably harmed people, with sort of people promoting unreliable observational data as the basis for changing treatment. You do need to prioritise and coordinate your trials so that you have efficient enrolment. You need to have commercial partnerships. Many of the drugs in the trial were provided free of charge by commercial partners, but run entirely by us. And you do need trust and confidence, both of healthcare staff, politicians, but also the public, to really get the trials up and running. So new opportunities, I think we've shown that smart design, data linkage, streamlined operations can make a big difference, especially if you're integrating randomization with routine healthcare and routine data systems, and regulatory approaches need to catch up with that type of trial design to improve patient care and public health at better costs. This just shows you that the proportion of all patients by hospital recruited into recovery, the orange dots, and you can see that some hospitals in the UK were recruiting at 35 to 40% of all the patients were going into the trial, and the average was about 10%. So really embedding research in clinical practice, where you're enrolling a significant proportion of all patients into clinical trials. And this picture here is of an intensive care unit admission board. And anyone who's been on an intensive care unit or any hospital ward really will know you have these boards where you have the patient name, admission, diagnosis, treatment, etc. And so here, all the patients had COVID, and what this is showing is that they've added a column for which COVID trial the patient is in. Most of the patients are in a trial, either recovery or one patient on remap cap, and this is really integrating research into routine clinical care. It's on the front line in the admissions board, which trial are you in, and that's really made a huge difference. So just I'd like to finish there by thanking obviously the funders, but really most importantly the huge team here at Oxford that have made this possible, but all the thousands, many thousands of doctors, nurses, pharmacists, healthcare professionals who've worked under extremely difficult circumstances and continue to enrol patients into recovery, thereby improving care of patients worldwide. Thank you very much.
Thank you very much for your nice presentation. Now we have questions and answers, okay? Q&A. So I'm gonna introduce the first question. Hi, Peter, thanks for the sharing. How do you see recovery being sustained or on standby for the next outbreak and become global? Does it overlap with WHO solidarity?
So I think
that's the question.
Yeah, thank you. So it's a good question. We wish it to become sustainable. And so we're actually now hoping to move to including other respiratory viral infections, so that the platform will become a platform trial for any hospitalized patient with a viral respiratory pneumonia, including, say, influenza or RSV. There are challenges to that, including regulatory challenges, which we're trying to overcome. And I think that's the way for sustainability, is to make these things platform trials for disease syndromes, so that if we can continue enrolling patients, and as new COVID treatments come along or improved COVID treatments, we can evaluate them. And then as treatments for influenza or RSV come along, we can also evaluate those. And that way you have a sustainable platform which is up and running, so that when there's another outbreak of a disease, you can just change the inclusion criteria and include those patients. And we are actively working to expand internationally, so to set it up as an international platform trial. Yeah, that's I think how we can do it. I think these platform trials have shown their value in many ways, and they really need to be invested in and sustained. That they really will help patient care. The WHO solidarity trial is obviously separate. We talk with them about what drugs are included in the different trial platforms, but at the moment they're separate. But there is plenty of space for multiple platform trials.
Okay, thank you. Actually, we have another speaker, but actually he did not show up. So actually, it's very odd that it's very difficult. So maybe we have more time to discuss with you. Actually, we have only one question, but actually we can discuss a little bit more, because the other speaker did not show up. So Dr. Tsang, do you have any question?
Yes, yes, thanks. Thanks, Professor Horby, for your excellent talk on the recovery trial. I think this trial is a very important and a very extraordinary studies which help the world in general, and also in terms extraordinary in terms of the timing. You show us that you can recruit patient in a short period of time, and also in terms of the size and also the results. So congratulate Professor Horby and your team on having that success. But having said that, can you tell us something about the difficulty that you encounter during your studies? It's so difficult in outbreak settings to hold these studies with several hundred, different places with a lot of difference in their practice. And also, you are talking about the symptomatologies, but in general, not the other parameters like the viral load, and also, there is a variation in the practice. How can you overcome this problem of variation in practice and also the outcome variables? Because you are basically you're looking at the outbreak, you're looking at the mortality, you're looking at whether there's some improvements in terms of the oxygen usage and some other things. But what about the other outcomes like viral load? Would that be important?
Yeah, I think you need to design your trial for the context, and there are outbreaks where there's not many patients, or they're very difficult to enroll. And a good example of that would be human cases of avian influenza, where you have hundreds of cases, but they're distributed over time in hospitals, and very different sort of trial would be needed there. When you've got common infections and large numbers, then I think the key decision was going for an unbiased outcome of mortality, which means you can go for a non-placebo controlled trial because you haven't got to worry so much about biased outcome assessment based on knowledge of treatment allocation. So that made a big difference. And I think what people often do, I think, is they compensate for a lack of patients by going for composite outcomes or surrogate measures, like viral load or the WHO ordinal scale and things like that. Whereas actually, if you've got enough patients, just go for something that really matters, which is, does the patient get out of hospital alive or not? And then regardless of what happens to their CRP or their viral load, it doesn't really matter. If it improves their mortality outcome, that's what they really care about. But there are some things, there are some limitations of the recovery trial. One is the level of safety data that's collected. For repurposed drugs, it doesn't matter so much because you already know the safety profile of aspirin. You don't need us collecting data on aspirin safety in another 10,000 patients is not going to improve on what we've known about aspirin for the last 40 years. Hundreds of millions of people taking it. So it doesn't matter so much there, but it does matter with new investigational products. So we've had to put in place sub-studies to do that. And the same is true of antivirals. So, one thing you would be interested in is resistance. And so you should probably put in place, which we're hoping to do, for example, if we put any of the new antivirals in, is to put in place sub-studies to look at resistance. So, but you don't necessarily need resistance data on all the patients, on 4,000 patients. You only need it on a subset. So I think the way to tackle that is you put in place sub-studies in a subset of hospitals where you look at sort of other factors that complicate the trial, like taking samples for resistance. In terms of variations in practice and things like that, I think the key issue is that if the trial's big enough, then the randomization and etc. Kind of washes that all out, and so you end up with very good balance between all the sites and the arms in terms of the baseline characteristics and what treatments patients are given. And I think it's a lesson for countries that have got more centralized healthcare systems and big healthcare systems. China would be a good example of that, where you could easily set up big platform trials across a number of very large hospitals in China and have very efficient platform for evaluating new interventions.
Thank you.
Okay, we have another question from the audience. Okay, some of the clinical challenges with the use of immunomodulators like dexamethasone, tocilizumab, baricitinib are their use in importance of subpopulations, in particular transplant, hematology, immunocompromised cohorts. How do large platforms trials go about trying to address the benefit of these drugs in these populations and adjusting for a multitude of factors in these complex subgroups?
Yeah, so we don't exclude anybody from the trials unless the clinician thinks there's a definite contraindication to that drug. So we want to sort of look at the applicability of the treatments to all patient groups. Now, if you want to look at specific subgroups, we can do that in the trial, but the trial, you have to be very cautious about the interpretation, because once you get into subgroup analyses, you're doing a lot of subgroup analyses. There are increased chances of false positive, false negative results. So you do have to be very cautious about doing those kind of subgroup analyses. But you can look at them. And I think then, one trial will not answer all questions. So there may be questions about, dosage, for example. We showed that the Regeneron product was beneficial in seronegative patients, but we used a very high dose. Other trials are needed to say, well, could actually you half the dose and have the same benefit? And other trials will be needed for special populations, etc. We've had questions before about multiple, collecting lots of information on the patients about, what was their Apache score or other things. But essentially, it doesn't matter, because the patients are randomized. So you get whatever their Apache score is, it's balanced between the randomized groups. And so, what you can see is that it benefits the patients overall. And so then you should use it in the patients overall, and trying to subdivide by multiple sort of physiological parameters or whatever really isn't needed, because they're balanced across the groups because of the randomizations, and isn't helpful, because eventually you'll find, if you look at enough comparisons, eventually you'll find one that's significant, but it's more likely to be an artifact than real.
Okay, so now this is the last question from the audience. Okay, it will be interesting to see if this momentum continues for other more mundane pathogens, particularly once the rapid ethics clearance pathways return to normal. I'm not sure what does that mean by, but can you explain a little bit?
Yeah. I mean, I think the wider lesson is, if you can do this, run a trial like this efficiently, for COVID-19. So, $500 a patient, 45,000 patients, 13 answers, or 13 drugs being evaluated, 9 answers within 2 years. That's incredibly efficient. It is light years different from regular clinical trials. Why can't you do this every day? Why can't you do this for cardiovascular disease, which is easier, because you're going to get cases all the time? Why can't you do it for COPD? Why can't you do it for cancers? And that's a question for the regulatory system. Is actually the regulatory system we've ended up with actually really hampering the advancement of healthcare? We've shown what is possible. Why can't this be replicated every day for all diseases? Why can't we get an answer on, 9 cardiovascular drugs in 2 years? There's enough patients with heart disease to do that. So I think it's a really important question that we mustn't lose sight of, because what we don't want to do is to go back to the 621 days to enroll a patient. And I don't think, and I guess the point of giving talks like this is to make sure that the whole clinical community gets behind, basically a shake-up of the system, so that we can improve care much faster and much more efficiently in the future.
Okay,
Thank
Dr.
you,
Chang,
Professor Horby.
Chang,
Can I?
could you close the? Yeah,
Sorry?
please. Yeah, Dr.
Yes.
Chang.
Can
Yes.
I ask another
Yeah.
question?
Yeah,
Now,
yeah.
the other part of the world is, trying to get vaccinate people. And in UK, I think the vaccination rate has been quite high, it's maybe more than 80%, and you are going to have the third dose too. So what do you think about the effect of these vaccinations, or especially say you're going to have the third dose or even fourth dose later on? You will probably see a lot of asymptomatic case or pre-symptomatic case. And also the outcome variables may not, the size of the outcome variables may change over time if you get vaccinated. So what do you think, what do you expect the effect of the treatment that you're going to test out?
Yeah, we've seen that effect. So if you think back to the recruitment curve, it's a very high peak wave 1 and really high peak wave 2. And now we actually have more infections now in the UK than almost ever before. It's come down a bit, but we've had a huge peak in infections. But we've only had a small peak in admissions to hospital and recruitment to the trial. So yeah, it is reducing the number of patients in hospital, and so the recruitment rate has dropped. So if you translated the numbers of patients, the number of cases in the community that we have now back to the hospitalisation rates of a year ago, we would be expecting to be recruiting 200 patients a day, but we're recruiting about 40 or 50 a day. So it's reduced the recruitment rate, and the case fatality rate, our primary outcome, has reduced. So it was 25% of hospitalised patients in wave 1. It's now down to about 15% in patients enrolled in recovery. So it means you have to increase the sample size. So whereas previously we were going for about 5,000 patients randomized in a comparison, 2,500 versus 2,500, we've now had to increase it to about 7,500. So, over 3,000 versus 3,000. So it does mean that you need a bigger sample size, and it takes longer to accrue that sample size. The other alternative is to change the primary outcome, so to move away from just death, and so you could move away to a composite outcome of death or discharge alive within 28 days, which would improve your power a bit.
Okay. Now, besides the treatment, I think the most important objective of this recovery trial is to find out the most effective treatment for the COVID patients. Will you try to include other studies in, say, for example, people are talking about long COVID or post-COVID syndrome a lot? I think the size of the patients having this problem is growing, and especially for patients with a lot of risk factors, and also for those cases having various severe disease when they are infected. So will you plan, or is there any other plans on these long COVID patients, and also the treatments, and also be it say medication or be it behavioral, whether you would consider having to investigate the treatment for these growing numbers of long COVID cases?
So there's a number of approaches. I mean, one thing we're doing is we're following up the patients long term who are in recovery. So we have approval to follow up the patients for up to 10 years. So, one of the objectives will be to see if any of the treatments we have used in hospital alter the risk of long COVID. So, if you treated someone with dexamethasone in hospital, because we have a randomized group, does that change the probability of being diagnosed with long COVID later? But then other groups actually are looking at treatment of long COVID. So there's another group called HEAL, who are randomizing patients at discharge. Interventions to see if those treatments will reduce the risk of long COVID.
Okay, so I'm gonna give the last question. Then maybe it lasts almost 30 minutes. So Dr. Chang will close this session. Okay. The last question: do you think the applicability of the previous findings, such as dexamethasone from recovery are translatable to a post-vaccine population? Do you need to be restudied? Do they need to be restudied?
Yeah, I think some of them yes, some of them no is the answer. I think, the anti-inflammatories, I think yes, because, if you're a vaccine failure and you've got inflammatory lung disease, then I see no biological reason that the anti-inflammatories wouldn't still work. But I think it is different for some of the others, like the antivirals. And so for the monoclonal antibodies, we showed benefit only in those who were seronegative at baseline. And this was the vast majority of patients in that comparison were pre-vaccination. So that then leaves us with a dilemma that if you're a vaccine failure and you've got vaccine-related antibodies, is that equivalent to being seropositive for natural infection, in which we wouldn't see a benefit? So that has left us a dilemma about whether monoclonal antibodies might be given to patients who are vaccine breakthrough infections. And so I think that probably does need to be restudied, actually, is that there should be a study of the benefit of monoclonal antibodies in hospitalized patients with vaccine failure. So I think it very much depends on the intervention.
Dr. Tsang, please.
Yes, thank you, Professor Horby. I think although Dr. Ling can't be here to talk about the treatment for COVID patients, but we did learn a lot from Professor Horby about the recovery trial and also the approach of having the studies. So with that, I would like to close the sessions and thanks the audience for joining us. We hope to see you some days in some other meetings. Thank you very much.
Thank you very much.
Thank you.
Bye-bye.
Bye.